Hi, everyone. Good evening. Welcome to our webinar tonight. We're going to be discussing a favorite topic, clinically relevant anatomy for the USMLE board exams. My name is Mike Stevens. I am a PGY3 dermatology resident and a tutor with Blueprint and med school tutors for over 4 years now. I'm thrilled to be hosting this webinar tonight and thrilled to be joined by my co-host, Dr. Bertino.
Hey, Mike, how's it going?
Good, good. How are you?
I'm fantastic. Super glad to be doing this webinar with you and going through clinically relevant anatomy for the USMLE. It's a pretty big topic, a lot to cover in a short period of time, but we'll do our best. All right, let's move forward here.
And so just to take a quick second and give you guys a little bit more of a snapshot of who we are here at Blueprint. Really, our mission is to help you through every step of the medical training process, from first year of med school and all the way through to step 2, shelf exams, your applications for residency, step 3 after you've started residency, and even beyond into your board exams. There are a lot of things that fall under the umbrella of Blueprint, including the grant fighter study plan to help with developing a plan and sticking to it, the one-on-one tutoring and med school tutoring that we do, residency consulting, and then a great QBank, Roche review, QBank for preparation for all of your shelf exams. And so if you are interested, a lot of these come with trials and consults that come free of charge and are great opportunities for you to get to know a little bit more about the services that we offer. But moving on to our plan for this evening, the main focus is, of course, going to be on anatomy. And upfront to state it, anatomy is one of those things that, at the end of the day, a lot of it does come down to memorizing the content. You have to have a good sense of what normal anatomy is to have a sense of what pathophysiology will look like. The challenge that comes with anatomy is it can get easy to be overwhelmed. There is a lot of granular details that you can get further and further into, and knowing what's important and what's not important is oftentimes 90% of the battle here. And so what we're going to spend some time on is how to approach studying anatomy, how to approach an anatomy question in of itself, how to dissect that down, if you will. We're going to spend a lot of time going through just practice questions. And that's going to relate to some of the kind of the big 4 that I pulled down: cardiopulmonary anatomy, basically your thorax, the mediastinum, the heart, the lungs, kind of everything around them. The gastrointestinal anatomy, and that's going to be a lot of the GI and abdominal anatomy. Neuroanatomy is going to relate a lot to the head and neck, kind of things that you have to think through, as well as some of the fundamentals of neurology. And then some musculoskeletal anatomy, everyone's favorites, the brachial plexus and the lumbosacral plexus and all of that. My favorite part of the webinar is going to come at the very end, where we'll have a live Q&A session. If you guys, a couple of housekeeping things actually, just to make you all aware of. As we're going through the webinar, if you have any questions, please feel free to drop them in the chat. We'll do our best to address them in real time. Anything that we're not able to get to, we'll certainly address in the Q&A at the end. And then at the end, we'll have a very, very brief survey that truly takes about 30 seconds of your time. I know you guys get inundated with these things a ton. Really, it's super helpful for us to be able to further refine the webinars that we deliver and make sure that we're providing something that's helpful to you all. But just keep the line of communication open through the chat, and we'll be kind of crowdsourcing a little bit in terms of questions and trying to get you guys engaged. So just keep your chat open. And so with that, we can go ahead and dive into how to approach it all. And so I guess I'll start off just by asking Fred, how did you go about studying for anatomy with the board exams?
Yeah, great starter question, Michael. I think anatomy can be a very daunting subject for a lot of people studying for the exam. It does have a tendency to come back in various ways throughout the step exam. So step 1 is going to be a lot more kind of your gross anatomy, like, do you know this or do you not know this kind of question, focusing a lot more on small details. embryology has a tendency to make a very big appearance in anatomy sections and anatomy-based questions on the USMLE Step 1 and the COMLEX Level 1. Moving forward, on Step 2 and Step 3, you will see a lot more transition of anatomy into the form of various pathologies that can be directly related to an anatomic problem. And for that, they're going to ask more in terms of a clinical context. So that's where I found more imaging-based questions relative to anatomy coming more into play. Very basic imaging on the USMLE Step 1 tends, I think, to more just kind of assert whether you all know where something should be normally in the body. It's very unusual that you're going to have a question that's asking you for abnormal locations of things. So when they ask you, like, hey, is the heart in the right spot? If you know where the heart is supposed to be on a cross-sectional image, then you should be able to identify that and get the question right. Pathology typically will show up later on step exams when it's dealing with image-based questions. Hopefully some of you joined our webinar last night where we talked about a lot of those pathologies that can be found on imaging, and we'll integrate as much more imaging as we can today to help you remember some of the normal anatomy on imaging also. But how I approached it basically was just that, I took what I needed to know, which was kind of like, where is everything in its proper location as a Step 1 student? And as I got further on, I focused a little bit more on pathology and how that could be directly related to anatomy.
That's awesome. I couldn't agree more. And, I think again, you want to focus on that clinical relevance and making sure that what you're spending your time reviewing is clinically relevant in some meaningful way. Because again, you can get lost in the weeds, but what they're going to test you on is going to be content that is applicable to patient care. And so I think that's kind of our points in the first couple of bullets here. And then just to give you guys a framework, if you are looking for resources or you need to use, it depends on what exam you're studying for, of course. I think that Step 1 is going to have a lot more of the kind of nitty gritty of anatomy. And then as you get further and further from Step 1, it's going to become even more and more clinically relevant. But the truth is that first aid for the USMLE Step 1 is an excellent resource to kind of hone in on that. I also like this roadmap for gross anatomy as a decent one that I used as a medical student. Anatomy isn't really changing in real time. It might be a little bit like having a high opinion of ourselves to say that we figured everything out. We certainly haven't, but the bare bones anatomy that you need to know for this test has been around and pretty established. And so it's okay if you're not using the 2022 version of any of these things. By and large, it's going to work. But the truth is that, and I think I sound like a broken record off of questions, as many as you can. And I think more than anything, having a good Q bank, looking at the kinds of anatomy questions that they ask in that Q bank is going to really help you get a sense for what you need to know and what you don't need to know. And I think just having a framework, organized by organ system, cardiopulmonary anatomy, and not in a dissimilar way to how we're kind of structuring this, but you have head and neck anatomy, you have your extremities, and then you have the thorax and abdomen. But our hope is that by the end of this webinar tonight, you'll have a good sense of what we talked about in terms of content, as well as what you should do to accrue more content going forward. So moving on to how to approach an anatomy question in general. And so kind of thinking through this, there are different flavors, of course. And a lot of times you're just going to have a bland, text question. If someone has an injury to this portion of their abdomen at this, dermatomal level, what underlying structures might be affected? Pretty straightforward. You kind of either know it or you don't. You might, you can use a lot of context clues to help you intuit things, but at the end of the day, a lot of this will boil down to memorization. And then there are going to be a lot of image questions as well that fold under the anatomy umbrella. And so radiology, gross pathology, and then they'll often include schematics, kind of cartoon diagrams that stylize the characteristic anatomy. I'll tell you that, and it relates to this pearl at the bottom. If you're ever given an image, they're often included as a clue to a differential diagnosis that you're already generating from the vignette. They're going to have buzzwords that help tip you off to a diagnosis, tip you off to a course, specific diagnosis that you can use the image to help confirm a suspicion for. I often use this phrase hidden buzzword. They're going to, oftentimes what they'll do is they'll embed something in the picture that you're looking at. It's a cavitary lesion. It's, in this case of chronic pancreatitis, you see these pancreatic calcifications. There's something in the imaging that they're including to help tip you off to a diagnosis. You have to have a sense of what you're looking at. So in this example of chronic pancreatitis, you see these brighter spots. So you need to first know that that's not typical for what we would be expecting. You need to know that you're looking at the pancreas right there and have a sense of where anatomically a structure, where this abnormality that you've detected would be, like what would be living there. And so that is kind of where you know, how to approach the radiology questions. And the same thing applies for the gross pathology and the schematics. I do find personally, I find that the schematics are a little bit easier because they stylize an ideal version of what the anatomy is. And so you kind of have an easier sense of what you're looking at. Anything else you'd add, Fred, about how you approach these things?
No, I think that all makes a lot of sense, Michael. What you said about the hidden buzzword, I can't emphasize enough. When they're showing you something in the vignette, there's as we said last night, actually, there's like a 90 to 99% chance that you will figure out exactly what's going on in the vignette itself. You oftentimes do not need the image to come to a diagnosis. Right. But when you have the image available to you and you feel quite strong about them, and that's what these webinars are designed to do. It's kind of confirmatory to know that what you thought is correct is actually correct, having that image to confirm what you were thinking about. So keep that in mind as you approach some of these anatomy questions going forward. So I guess we'll start here with some cardiopulmonary anatomy. And if I may take over the screen just for a moment here, I think it would be helpful for us all to have a slight cardiopulmonary anatomy review. So I'm going to kind of switch gears here for a moment. And I don't know if you can all see my screen. Is my screen visible in some way, shape, or form?
I think we're still seeing the cardiopulmonary anatomy.
Okay, let me try this a different way here. We're going to make this work one way or another. And we'll take you all through some good anatomic tutorial here. So let's do this. Let's do all right. Here we go. How about that? Are we able to see things now?
Looks beautiful.
Amazing. All right. So what I am showing you all here, and I'll kind of make this a little bit bigger so I can actually point to things a lot more accurately, is a quick tutorial in sort of chest and cardiopulmonary anatomy. What I'm showing you here as I'm scrolling through these things is we've got on my image left over here, this is an axial orientation of a CT scan that I'm showing you. I think about axial as an orientation of anatomy where I'm taking a loaf of bread and I'm cutting that loaf of bread in the way that I would expect a long loaf of bread to be cut to make individual slices of it. So think about how it comes from the grocery store. That is how I think about an axial slice. This on my image right over here is as if I'm talking to Michael in person. He and I are facing each other and I'm looking at Michael, and this is basically what I see. I call this the coronal view here. I've essentially taken that slice of bread and cut it in basically the up-down parameter. So basically I'm moving anterior to posterior as I scroll through this CT image here. So I'm going to correlate kind of our axial and our coronal images here to show you our cardiopulmonary anatomy as we move through these various areas. So starting up here at the neck, I can see a few anatomic structures that I know you've all encountered in medical school. This bony structure that I'm pointing out here with my mouse here is surrounding the airway. It's lower down in the neck, just underneath the mandible, which we're catching the very tip of anteriorly here. And in the human body, there's only two real bones, at least two bones that come to mind that really don't touch or truly make a major joint with any other bone or touching it. And one of these bones, you might say, well, that doesn't really count. It actually does make a joint. So arguably, this is the only bone in the body that really doesn't articulate with any other bone in the human body. And that being said, this is going to be your hyoid bone right over here, if you remember that from anatomy. On both sides of my hyoid bone, I've got several circles that I'm admiring over here. The outer, more large and squishable ovoid circle over here is going to be my internal jugular vein. Okay, and on my coronal, I can correlate that over here. And the smaller, rounder, muscular circle, because it's smaller, is going to be my carotid artery. So showing you the relationship there, your jugular vein tends to be a bit more superficial than your carotid artery. My airway, as I said before, is in the middle. And this bright organ that is straddling my airway in the middle between these vessels is my thyroid gland. Okay, it's bright on CT scans.
I'm going to jump in real quick. I think we're not able to see your pointer.
Oh, we're not able to see the pointer. Oh, that's suboptimal. Let's try this. My screen sharing is paused. Why is it paused? Let's try this. Able to see pointer now?
Yes, perfect.
Perfect. Thank you for that feedback. That was very helpful. So real quick to recap, showing up here, A-shaped bone that doesn't articulate with any other bone in the body. This is my hyoid. The airway is right in the middle of it. My ovoid, squishable, larger circle toward the outer portion of the neck over here is my internal jugular vein. My smaller, more round, muscular, and very much a circular structure that always stays circular is going to be my carotid artery deep to that internal jugular vein. As I go lower, the airway is this big black dot in the middle of my neck here. Straddling that is a hyperdense organ here. This is my thyroid gland that sits right on top of my trachea. You all know this from doing your OSCEs and your physical exam practices, having people swallow, getting that thyroid to move up and down. That is what you are palpating. You can find nodules in it if you do your exam the right way. Posterior over here, we've got our vertebral body. We're entering our thoracic vertebra over here. In the middle of the vertebral body is going to be our spinal cord, as I'm pointing there. Going back anterior, we've got two bones that come from the side and travel in a sort of an S-shaped configuration as it joins the manubrium of the sternum. And these bones over here are my clavicles that come in from the side, join the acromioclavicular joint over here, all the way back to the manubrium of the sternum. Heading a little bit more south in my axial plane here, I'm getting into the mediastinum. There's a superior mediastinum, which includes my thyroid gland. And as I continue lower, my upper mediastinum contains my airway over here, the bigger, more rigid circle. Okay, remember that your thyroid is going to have C-shaped cartilages that are anterior on that ring, and posterior, there is no cartilage. So posteriorly, you can compress that trachea. And to the left of it over here, remember radiology left, it looks like it's on the right side of the screen. So we have to flip our orientation when we're looking at imaging. But this smaller air-filled tube to the left of my trachea is my esophagus. That is a normal location of the esophagus in the upper chest. Coming down here, this leftward pointing structure over here is my heart. That's a pretty easy one. This darker band in the middle of it is my interventricular septum. On the right side of the image here, the first portion of the heart that I descend into is my right atrium. Going anterior and inferior, I've got this triangular chamber right here, which is my right ventricle. Remember, the right ventricle is going to be the anterior most chamber in the chest. Remember, people with stab wounds to the chest with a penetrating injury to the heart, the most likely chamber you'll probably hit is going to be that right ventricle. And then immediately posterior to that, on the opposite side of this big muscular wall, you can see that this wall is far more muscular than the right side. This is my left ventricle. And then just north of that, the most posterior chamber in the heart is going to be my left atrium. Looking at some of my great vessels as I ascend upward, coming from the right ventricle down here, I'm tracing this upward. We're going superior, superior, superior. This vessel wrapping around and branching into two main branches to each lung are my pulmonary arteries over here. I'm showing you on my coronal over here, the correlate on the other side. Let me get there. This is the right ventricular outflow tract. My mouse is hovering over this and it bifurcates into the left and the right pulmonary arteries. My left atrium should have normally 4 normal pulmonary veins that enter back into the left atrium. We can see the superior veins, there are paired superior veins, and then paired inferior veins, 4 of them that end up back into the left atrium. Remember that for some of you in your pediatric shelf, if you're a second or third year medical student, I should say, or maybe you're studying a pediatrics unit right now, as a radiologist, I'm counting these pulmonary veins in our little kids all the time, because if they've only got 2 or 3 of them that wind up going back to the left atrium, one of them might be going back to somewhere else. And if it's going back somewhere else, then I can call that a partial anomalous pulmonary venous return. And if all of them are going somewhere else, then it's a total anomalous pulmonary venous return. That's a congenital heart disease, one of those terrible T's that you need to know, which is a cyanotic heart disease. My other great vessel in the chest, we take our left atrium, left ventricle, big muscular wall around here. That's how you can identify this. We're tracing it upward, big circle here, up, 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 up. And it goes from an anterior right side over an arch like a hook shot down posterior and to the left side of the chest along the posterior aspect. This is my aortic arch. If I trace the aortic arch northward, I've got 3 main branches of that aortic arch. My first branch is going to be my right brachiocephalic artery. My second branch is going to be my left common carotid artery, and my third branch off the aorta is my left subclavian artery. Continuing downward, my descending aorta continues down to the diaphragmatic hiatus. And just to very briefly show you what lungs look like on a CT scan, I'm shifting now to my lung windows. What we can see here are lung architecture. So aerated lung is going to look black on a CT scan. All of these white linear densities that extend outward are my pulmonary vessels. They are a mixture of pulmonary arteries and veins. And if I've got a white border around a donut of blackness inside of these lungs, those are my airways. So I can basically predict what kind of pathologies I can find. If it's a pneumonia, I would expect some of this aerated alveolar tissue, this dark stuff, to become brighter. That's consolidation. If I had mucus plugging, I would expect my black donuts here to be filled in with white goo. And if I had bronchiectasis, I would expect my dark donuts here to be much larger than they are appearing here, and they would look quite big and noticeable all the way out to the periphery, which is very abnormal and characteristic of bronchiectasis. So that's kind of the major anatomic structures of the mediastinum, the chest, and the cardiopulmonary anatomy. If I can get some decent resolution here, which I can't, unfortunately, on the CT scan, there's just a little bit too much motion artifact, but I will show you 2 additional structures. Immediately coming off the aorta is this contrast enhanced linear structure. And if I were to trace it down, I'd ask you to believe me and hallucinate this with me, but it's traveling essentially down the interventricular septum of the heart. So it's going along the left ventricle. That's going to be my left coronary artery. It branches into 2 branches, one going into the interventricular septum, that's my LAD, and then my circumflex should come around to the back. And you can see the origin of this other linear structure going rightward. This is my right coronary artery, also wrapping around the heart, going to the back. And I think that's a pretty good place to stop in terms of our normal anatomy of the chest and heart.
That was amazing. I feel like I learned a ton myself just now. Thank you so much for that. I really have to tip my hat to you. That was awesome.
We're going to come back to the abdomen after we go through some practice questions. Can you all see the PowerPoint presentation again?
I think we're good. I think we're back on cardiopulmonary anatomy.
Fantastic. Michael, would you like to take this first question, or would you like to throw it to me?
I can take it from here, and I'll give you a break, Fred. So our first question up front, we are going to apply directly what we have just talked about, and so I think we can use this opportunity to practice a little bit of just how to approach questions in general. What I like to do with any practice question is start with the question itself. So which of the following is the patient most likely to have? I'm dealing with a diagnostic question here. I need to figure out what the diagnosis is. I see a picture, and so I'm also kind of inclined to glance at that and see if anything stands out to me. And so, if you guys think at any point, feel free to chime in, but I'm going to take it from the top and go from the very beginning. A 33-year-old man without past medical history presents with severe chest pain radiating to the back and characterizes that chest pain as tearing. So it developed suddenly about 1 hour prior to presentation, and his vitals are notable for, it stands out to me as he's tachycardic, and he has his blood pressure differential. So it's 148/99 in the right arm and 97/62 in the left arm. And on physical exam, he has a depression in the lower chest. He's tall and he has long arms. And so I'll challenge you guys. Let's start with what's going on with we have this image here. Where is the problem, and what would you diagnose that problem as? And so you guys feel free to chime in. I love that people are already kind of honing right in on the answer, which is amazing. Great, awesome. A lot of people are chiming in. Keep it coming. Perfect. Okay, so this structure here, this kind of dilated structure here, you see basically this line down the middle, and that represents that we're looking at the aorta. And that aorta, that line down the middle, is what demarcates the true lumen from the false lumen. And when you have that false lumen, you really have a part of the wall that has kind of lifted off that you are tearing into. And this is what we term an aortic dissection. So this is an example of an aortic dissection. I didn't even realize, I guess that the reference at the bottom kind of gives the answer. I'm sorry, guys, if you have honed in on that. That might be a running thing because the Radiopedia articles all have the diagnosis in the URL. But okay, so we're dealing with an aortic dissection. Now the question is, why is this guy having an aortic dissection? So there's a couple of things in this vignette. He has depression in the lower chest, tall stature, long arms. What does that make you guys think of? And like, perfect, I love it. People are so on it. This is Marfan syndrome, exactly. So we're looking for which of the following would be consistent with Marfan syndrome. And so, awesome, great job, guys. So the answer is A. So mutation in fibrillin 1 is the genetic mutation that causes Marfan syndrome. Does anyone know what the term is for the depression in the lower chest? Like the upper abdomen. Does anyone know what that's called? This is kind of an extra credit. Yeah, awesome. Oh my gosh, you guys are so on it. Pectus excavatum. That's exactly right. Oh wow, I'm so I think I'm really impressed with you guys. All right, perfect. Let's quickly run through the other answer choices because all of these relate to other diagnoses. So trinucleotide repeat on chromosome 9. This is also kind of a harder one. Maybe a little bit more extra credit. Any thoughts on that? The trinucleotide repeat diseases, Fragile X is a good thought. It's one of them. The trinucleotide repeat diseases, there's kind of a short list of them, kind of high yield. This is that would be an example of Friedreich's ataxia. So B would be Friedreich's ataxia. C, mutation in the RET proto-oncogene. Does anyone know what that would cause? Yeah, perfect. MEN2. And so that's a tricky one because it can cause that Marfanoid habitus that we're seeing. But Marfan syndrome is what we're looking for with that aortic dissection. Elevated levels of homocysteine. Thoughts on that? Yeah, homocystinuria. That's another one that causes that Marfanoid habitus. So the physical exam there is not pathognomonic. It brings up a differential diagnosis, but in the context of the dissection, really kind of honing in and in the right substrate, this 33-year-old man, I think the most likely answer here would be Marfan's. And then granulomatous large vessel vasculitis. What do you guys think about that? Giant cell arteritis is a great thought, and Takayasu arteritis could be another one that you'd think about. Awesome job, guys. That's great. That's great. You guys did phenomenally on that one. So we can go ahead and move on to the next slide that'll make sure we got the answer right. It is indeed A, mutation in fibrillin 1. Great work, guys. And then Fred, I'm happy to take this one too. And
I would love it if you would continue with it, and I can save my energy for going through some more CT stuff. So
let's do it. I want to make sure that you have all the bandwidth because I will have more of the imaging to go through in a little bit. All right. So again, same thing we're dealing with this question. We have a picture, we have some text. So it's going to be a multimodal question. The site of disease in this patient is at which label? And so you can really, the answer choices kind of directly map onto the angiogram that we're seeing here. And so we're going to take it from the top. A 53-year-old man without past medical history presents with severe crushing chest pain that develops suddenly 1 hour prior to presentation. This isn't tearing chest pain. This is crushing chest pain. He has a past medical history of diabetes, hypertension, and hyperlipidemia. His vitals, he's tachycardic as well, a little hypertensive. And then his EKG is a little concerning. He has ST segment elevations in leads 1, AVL, V5, and V6. And he has ST depression in leads 2, 3, and AVF. So what do you guys make of that? What's going on in this guy? Let's start with what the diagnosis is. Great. Love it. Keep it coming. Awesome job. So a lot of people are chiming in MI. And some people are even throwing in the distribution of the MI. So let's hone a little bit more into that point. What part of the heart is affected in this patient? What coronary artery, which, if you had to guess, would be involved? Okay, great. I love it. We've got a little bit of a dialogue of back and forth. Some people are saying left anterior descending. Some people are thinking left circumflex. Some people are thinking left main coronary artery. And then we got some votes for the right-sided circulation. So I'll tell you my mnemonic for dealing with this. What you care about is where the elevations are. And we see elevations in 1, AVL, V5, and V6. So, and this is a little bit, you can look at the kind of triangle that's created with the leads and kind of memorize it that way. I honestly am not that smart, and I have just used a mnemonic to help me. 1 and AVL are lateral leads, and I use the L in AVL and the L in lateral to help me keep that straight. 2, 3, and AVF are going to be your right-sided leads, and those correspond to the inferior leads. And I use the F in AVF and the F in inferior to help me keep that straight. And then for anteroseptal, if you think about, and we're going to have a schematic if this doesn't make sense in subsequent slides, but if you think about the way that the precordial leads come out of the chest, V1 is kind of coming directly out, maybe a little bit to your right, V2 directly out, V3, V4, V5, V6, you're progressively going more around the heart to the side. And so you, again, have to have an idea of how the heart is oriented in the chest. V1 and 2 are going to be, V1 and V2 are going to be very much your septal leads. V3 and V4 are going to be more anterior, and then V5 and V6 are going to be more lateral. And so to me, I think of V1 through V4 as more of your left anterior descending circulation. I think of V5 and V6 getting a little bit more into that left circumflex territory again. So putting this all together, what coronary artery is diseased in this patient? Perfect. Awesome. You guys got it. You guys are excellent. Great work. So the left circumflex. This is a tough question to state. This is a third order question. You have to figure out what the diagnosis is, recognize he's having a STEMI. You have to figure out where the STEMI is and recognize it's the lateral circumflex. You need to know that corresponds to the left circumflex. And now finally, you need to know the anatomy to be able to pair that with this coronary angiogram. And this is a hard question. This is not, straightforward kind of, you kind of have to know what you're looking at here. So what label corresponds to the left circumflex artery? Okay, I see some votes coming in. Keep it coming, guys. What number on this angiogram? What answer choice would you pick?
So allow me to chime in with a little bit of some test-taking gamesmanship here. Okay, so we talked about in our CT evaluation before this, when I was going through the origins of the coronary arteries, I made mention to note that the LAD branches into, I shouldn't say LAD, I should say the left coronary artery branches into 2 main branches in the heart. The RCA, the right coronary artery, branches into only really the one that travels around the back of the heart. So here's a fun tip, is that if you're given some sort of a coronary angiogram or a diagram on the exam, consider that if you're seeing 2 large vessels opacifying with contrast, you're probably looking at the left coronary artery. And if you see 1 only opacify, you're probably looking at the right coronary artery on the step 1 level of kinds of things. Again, now, if you're preparing for your interventional cardiology board exam, I can't help you there. That's going to be a little bit more nuanced. Now, something else that we said before in our CT evaluation was that the LAD takes what course along the heart? Is it a ventricular septal course, or does it wrap around the back of the heart? And you should know this based on how those arteries are named. Yeah, it's going to go down the ventricular septal course as well. And if it's going down the ventricular septum, that's a pretty big muscle. So you can imagine the LAD should be the vessel with lots of perforating branches that come off of that and have to go into the muscle. So of the two arteries you're seeing here in this image, the one with the more perforating branches is probably your LAD. So I'm going to turn things back to Michael now that we may have oriented ourselves on this angiogram.
I love that. That is excellent testing. So it is a little tricky. You kind of do have to orient yourself to what you're looking at here. Any other guesses based on that? Great, love it. You guys got it. So if it's not the one with a lot of branches coming off of it, which would be the basically 2, and then the branches being 3 and 4, your other main artery coming off of the left main coronary artery, which is labeled by 1, is going to be 5. And so 5 is the way I think about it is you're kind of looking at the heart from the side. You're seeing the LAD come down the anterior surface, and that's what you're seeing transversely going across. And then the circumflex is actually wrapping around the side laterally. And so it looks like it's going straight down. It's actually going around. And so if you, so great. The answer here happens to be 5. And this is a tough question. We're really pushing you guys a little bit to those higher level questions. But this is a good example of getting familiar with what coronary angiography looks like. And so if we go one more slide, we'll get an image of what, the label version of that, and the quality is not as great as the original one, but this is labeled, so you can kind of orient yourself a little bit more. Again, notice that left circumflex is coming around the side there. And then just to restate it again, so you guys have a sense of how the leads are coming out of the chest, again, to help you get an idea. V1, V2, think more about that septum. V3, V4, think about that anterior circulation. That's going to be your LAD. V3 and V4, think a lot about LAD. Once you're getting out into V5 and V6, you're back into left circumflex territory, just to give you guys a sense of where the MI is happening. Awesome job, though. All right, so moving on. We'll take a brief segue. So we had a great foray through the CT imaging. Fred, can you give us just a quick snapshot of what we're looking at on a chest X-ray?
100%. So chest radiography is probably going to be the more common imaging that you will see on your step exams. And I will even make a guess here, or an accusation, in that step 2 and step 3 are going to have a lot more chest radiographs with a lot more pathology in them for you to know. Sometimes you'll have anatomy questions on chest radiography in your step 1 exam if you are at that level now. So always good to learn some of this information. If you listened to our webinar last night, we talked about a mnemonic of A, B, C, D, E, which is a nice way to go through a chest radiograph. It's probably one of the first search patterns that most medical students and medical professionals learn. And we can kind of take a look to see exactly what A, B, C, D, E means. And you can keep this in your back pocket for when you start rotating on the wards if you haven't already done so. You'll look like a champion being the person to know how to look at a chest X-ray from top to bottom. So starting with A, I'm thinking A stands for airway. So for airway, I'm looking at my trachea, which is this midline lucent. When I say lucent, I mean we can penetrate X-rays through it quite easily. So therefore, it must be filled with air. And it branches, if you can hallucinate with me, at the point of the bifurcation of the trachea called the carina. The carina ends around right here where my cursor is focused. The trachea should be a midline structure. And ideally, if you've positioned this patient properly on the X-ray table, we should be able to see spinous processes, which are these little oval circles here, project beautifully through the trachea. So that's kind of a nice little landmark for you. Going down now, letter B, I'm thinking B stands for bone. So this is an opportunity for me to look at my osseous structures. I'll start at the top here. Again, these are my S-shaped bones all the way at the top. These are my clavicles that go from the acromioclavicular joint with the scapula all the way down through the manubrium, which is not very well seen here because this is a posteral anterior chest radiograph. There's just too many structures superimposed for you to get the delineation of the sternum out on a chest radiograph normally. here's my other clavicle right over here. I'm taking a look at my acromioclavicular joints. Again, not the best study to evaluate these joints. You're going to want a dedicated shoulder or a clavicular radiograph to look at these, but you can still see them here. This is these joints. This is my acromion process of my scapula on both sides. This triangular bone over here that's superimposed on some of these words. I apologize for that. You can see it over here as well, and it's kind of superimposed on the back of the lung field. This is my triangular shaped scapula projecting over my chest in the back. And then these are my humeral heads articulating with the glenoid fossa. So this is the glenohumeral joint, also known as the shoulder joint. A little bit of MSK anatomy. While X-ray is not the best way to evaluate these structures, you'd probably want to use an MRI to see a lot better soft tissue detail. Can our audience members please tell me the 4 muscles that contribute to the rotator cuff? This is an important question for your musculoskeletal anatomy questions. Go ahead and give me those 4 muscles that contribute to the rotator cuff. All right, first person to respond actually got it absolutely totally correct. Excellent job. That's going to be your supraspinatus, your infraspinatus, your teres minor, and your subscapularis. Those are your 4 rotator cuff muscles, not the deltoid. The deltoid does not contribute to the rotator cuff. So great job. It's your sits muscles, supra, infra, teres minor, and subscapularis. Great job. So going back to my bones, I'm looking at my ribs now. Rib fractures can be often missed, but also diagnosed on chest radiography, especially important to keep in your mind as a differential for chest pain. I think about ribs in terms of smiley faces and frowny faces. So if I'm seeing frowny faces over here, these are kind of my downward bowing ribs. I know that the frowny face ribs means that they are posterior ribs. And if I see smiley face ribs that kind of loop upward like this, like a smiley face, that means it is an anterior rib. And you can trace the rib from posterior to anterior as you go along. Okay, those are my bony structures. I'm also looking at the spine, taking a look at alignment, et cetera, et cetera. C is a great letter for my cardiac silhouette. So C means cardiac. I'm looking to see my aortic knob, which is this first bump on the left side of the chest X-ray. The second bump is going to be my left atrium / pulmonary venous inflow. This little bump all the way to the side of this second bump is going to be my left pulmonary hilum, so my left pulmonary artery coming out there. And then this third larger bump that extends leftward is my left ventricle. My right atrium is on the other side. Remember, we said that if we're thinking about lateral ventricles in the heart, the 2 lateral ones are going to be my right atrium on the right side and my left ventricle on the left side. My anterior most chamber that I can't really see here, probably about here if I had to guess, is my right ventricle, and my most posterior chamber is my left atrium. Aorta is a left-sided structure, so it's going to start on the right side, which you can barely see. It's going to loop all the way around here, and this is my aortic knob as it comes around, as it goes posterior and left in the chest. And then these sort of bat wing symbols right over here, these are my pulmonary hilum, my pulmonary arteries extending outward. This is just a big pulmonary artery going in both directions to the lower lobes. D is my diaphragm. I'm looking at the diaphragmatic contours and the borders right over here. I lose a bit of the diaphragmatic border on the left side because the heart is soft tissue density. The diaphragm is also soft tissue density. X-rays are not that smart. They cannot differentiate the difference between soft tissue and other types of soft tissue. So they just kind of blend into each other as we call a silhouette sign. So that's why I can't really continue to see my diaphragm all the way over here. I can see bits and pieces of it though, so I know it's pretty normal. There's normal silhouetting there. I'm looking for air under that diaphragm, which could suggest free intraperitoneal air in the abdomen. I'm looking for eventrations of diaphragm, which would be an irregularity. I'm looking for loops of bowel that have gone beyond the diaphragm, in which case, if this were a little baby, that would be a congenital diaphragmatic hernia, something to keep in mind when looking at chest radiography. Okay, I'm also looking at my costophrenic angles. Okay, these are going to be these pointy little angles between the costo, which is a nice fancy word for cartilage associated with your ribs, and phrenic, meaning diaphragm, because we know the phrenic nerve C345 keeps the diaphragm alive, is the junction of that angle there. And I look specifically in this location because this is going to be the earliest area on a frontal radiograph that you can identify a pleural effusion or sometimes basilar pneumothoraces. And lastly, E is kind of the dump truck of everything else. E is going to kind of be everything else. So you're looking for lines, tubes, you're looking for port catheters that might exist. You're looking for central venous catheters that might take aberrant courses like down the aorta, which is never a great idea. You want those to be in the veins. You're looking for stents that may have been placed. You're looking for any other kind of cardiac lead, any other kind of device that might be present on a patient. And then F, we'll extend our mnemonic to F, F meaning fields, fields being short for lung fields. So I actually reserve the lungs to the last thing I look as I go through the last thing would be the fields and looking to see how well they are aerated. I can find my consolidations. I can find pleural diseases like pneumothoraces or pleural effusions, etc. So that would basically be how I would take people through a chest radiograph. Equipped with that knowledge, you guys should be champions on the wards.
Awesome. Amazing as always. I feel like that, again, I feel like I'm learning so much along with everyone else tonight. All right, let's keep it going. We're going to move from the thorax and into more GI anatomy.
All right. At this point, are you cool if I jump over to the CT?
Let's do it. That sounds great.
Absolutely. So let's pivot here. We're going to go back to our CT scan, which is going to be this guy. Are we back? Can we see this?
Yes, perfect.
Fantastic. So that said, and we're scrolling here. So let's go under the diaphragm now and investigate our abdominal pelvic structures. Okay, so again, let's see if I can get ourselves a coronal abdomen pelvis, which I totally can. There we go. All right, so we're looking at abdominal structures over here. Again, I jump below the diaphragm. I can't really see the diaphragm as kind of as an organ here. If I were to go over to the sagittal, which again, this is kind of cutting someone down the middle now, if I were to think about a sagittal view, it's going to be this muscle that we see. Can't see, can we still not see the pointer actually now that I'm—
We're good. We can see the pointer just great.
Perfect, great. So this thin muscle over here is going to be your diaphragm. It separates the chest from the abdomen. We'll go back to our coronal section, cutting it the same way as I showed you before in the chest. And as I go below here, I encounter the first ginormous organ inside of the belly. This is my right-sided organ. It is the liver. Okay, liver has, excuse me, has a ton of biochemical processes and metabolic pathways that it carries out. I will not bore you all with those right now, but I can identify a couple of very crucial structures within the liver. This contrast-enhanced vein that starts outside of the liver and goes toward the liver and then branches off in a couple different directions is my portal vein. Now, some people might say, well, what is the major supply of blood to the liver? Is it the portal vein or the hepatic artery? I'll let our audience members chime in right now what they think to be the major blood contributor to the liver blood supply is. Absolutely correct. It is the portal vein. It supplies about 70 to 80% of blood flow to the liver versus the hepatic artery that supplies only about 20 to 30%. And there is one structure inside of our liver that is actually predominantly supplied by the hepatic artery. Does anybody know what that intrahepatic structure is? Not portal vein supplied, but hepatic artery supplied. It's going to be our bile ducts. So our bile ducts are supplied by the hepatic artery predominantly. Our gallbladder sits right underneath the liver anteriorly. So in the gallbladder fossa, this is this cystic structure that we're seeing over here. You can see this correlated on our coronal. Moving away from the portal vein and the liver structures, we go to the left side and we see our left-sided triangular organ in the left upper quadrant. This guy is going to be our spleen, another reticuloendothelial organ involved in immune processes, protecting us from encapsulated bacteria, among a bunch of other fun bugs. It can become deleted from our body in a specific disease. Which group of patients with what disease might lose their spleens automatically? Sickle cell anemia, correct. Autoinfarction of the spleen, terrific. And you'll notice that there's a big juicy vein that leaves the spleen called the splenic vein, and it joins into the portal vein as it drains into the liver. So the spleen is part of the portal venous system. It contributes portal blood to the liver as part of the immune function of the liver. And there's one vein that also extends quite below here that drains all of the small bowel. So it takes all of the nutrients into one vein and anastomoses with that splenic vein to create the portal vein as it enters the liver. What is the name of the vein that drains the small bowel and brings the nutrients to our liver? That's going to be the superior mesenteric vein. So SMV plus splenic vein equals portal vein. That's our portal venous system. Let's go now to the middle of the belly here. This is a retroperitoneal structure that in my mind looks like chewed up hamburger meat. It's right in the middle. It's kind of S-shaped, and it essentially extends from the back. We've got kind of an ill-defined head of it over here. It's got a body component over here, looks like a hot dog or chewed up hamburger meat, and it goes all the way to the tail, which tickles the splenic hilum. This is none other than our pancreas as it goes across. That's right. A lot of pancreatic pathologies that we can think about, but we won't go into all of them right now. Let's go backwards here into our retroperitoneum since we're on the topic. We're looking at two bean-shaped organs, avidly enhancing, paired. We've got two of them. These are our kidneys. Kidneys here have multiple different phases of enhancement on CT scans that you guys will not have to worry about for your exams. But what I do want you to think about is that you can go north of the kidneys and find wizard hats on top of both of your kidneys here. These wizard hat organs are our adrenal glands, and you may find a big mass sitting on top of the kidney. If you're seeing that, you're thinking about an adrenal adenoma or maybe even a pheochromocytoma, which has a very classic presentation that you guys are all very familiar with for your STEP exams. I know you are. So moving a little bit into the digestive nature of things, we've talked about our esophagus already as it courses through the gastroesophageal junction as it passes through the diaphragm. And this first very muscular bag of fluid-filled grandeur is none other than our stomach. So our stomach is a left upper quadrant organ. It's very muscular. It's got a nice border of muscle surrounding it. You can even see some of the little folds in it that we call rugae. Okay, and this is responsible for lots of digestive functions, not only just in digesting food with hydrochloric acid, but also releases intrinsic factor so that it can bind later in the duodenum and help us to absorb what vitamin? B12, fantastic. An absence in what cell of the stomach might result in somebody having pernicious anemia? Parietal cells. Nice job. So after the stomach, we join the duodenum, but not without passing through a very muscular portion of the stomach called the pylorus. The pylorus is here at the very end of the stomach as we join into our first portion of the duodenum that I'm showing you on our coronal view over here. And the correlate over here is this bit right here. This is the first part of the duodenum. There are four parts to it. The descending portion of the duodenum that goes straight up and down like an elevator lift in the back here is my second portion of the duodenum. My third portion of the duodenum goes again across midline as it extends this way. So this forms that duodenal C loop that we're all very familiar with. And then as it angles upward, okay, it's held upward in a suspended location by an anatomic structure. What anatomic structure holds the duodenum upward and separates the fourth portion of it at that level from the jejunum next? There's an anatomic structure that I want you all to be familiar with, and you've definitely heard it before, I promise you. Yes, the ligament of Trites. The ligament of Trites separates the fourth portion of the duodenum from the jejunum, and it is in that left upper quadrant right about this area, as I would say. You can see the duodenum kind of aiming upward before it turns into small bowel. This mass of small bowel over here on the left side of the abdomen is mostly jejunum. It's pretty dense. It's going to be pretty much sequestered to the left side. Okay, we can see it over here in our left upper quadrant. We can follow jejunum all the way down where it kind of sits in small bowel in the middle of the pelvis here. That's going to be predominantly ileum. And if we were to trace our ileum all the way to the right lower quadrant, we will eventually get to the ileocecal valve, okay, which connects our ileum to the first portion of our colon, which is our cecum, and therefore ascending colon. So our ascending colon is over here in our right lower quadrant. We extend all the way up here as we're going up to the hepatic flexure. We go across in this large bowel here. You can even see the large divisions of the large bowel here these little loops over here that kind of separate these. These are the haustra of the large intestine, okay? And this is my transverse colon as we go from the right side of the abdomen to the left side of the abdomen. This portion of colon is decompressed, but I assure you it is in fact the descending colon as we go all the way down here. This one portion of this descending colon that is now S-shaped is the sigmoid colon as it descends into the rectum, which is the most posterior structure in our pelvis. Finishing up with a couple of other anatomic points over here. Going deeper into the pelvis, we have, in this particular patient, this is a male patient. We've got anteriorly the urinary bladder, which is quite decompressed in this patient. Okay, it's going to be this kind of smiley face shaped structure. It's going to be quite anterior. Going a little bit posterior to the urinary bladder and inferior, this is our prostate gland in this male patient. And then posterior to the prostate gland, we can see the rectum back here. Going a bit further into our bony structures, and I'll turn on a bone window so we can see this a little bit better over here. I've got my femoral heads on my coronal view right here. This is the femoral head joining into the hip joint. This concave structure here of the iliac bone is called the acetabulum that forms that joint. This is my greater trochanter. This is my lesser trochanter over here of the femur. We've got our iliac bones, one on each side, our iliac wings. We've got our sacrum in the middle of these things. We have our L1 through L5 lumbar vertebrae. You know that the lumbar vertebrae begins after T12. And I know this is T12 because this is where the final rib originates from the thoracic vertebra. And I've got two large muscles that are in the back and they run along the lumbar vertebrae over here. These are my paired psoas muscles. All right. And then coming up, closing with some more vasculature, this large, circular, bigger, squishable structure over here is going to be my IVC. I know it's my IVC because it's right-sided. Veins in the belly have a tendency to be right-sided structures because they have to go to the right side of the heart. And big circular muscular vessels on the left side of the body tend to be my aorta, and arteries because they have to come from the left ventricle. So they descend here. At the aortic bifurcation, I'm seeing my paired common iliac arteries that descend along with my common iliac veins, and we descend into the lower extremity. And that concludes the quick run through of the abdominal pelvic structures on CT scan. So I'm going to bring things back. Hopefully, knowing what we know now, we can go back and figure things out. Oh, I have one bonus question that I absolutely have to ask, Michael. This is very important. This structure inside of my liver here, okay, is known as the falciform ligament, okay? And there is a structure here that is actually a remnant of a very old structure that we never really knew that we had, but we always knew that we have it because we all went to medical school. And you can see the remnant of this structure in the falciform ligament that separates the left and right hepatic lobe. Can anybody tell me what structure I might be referring to here? Like Ligament of Trites, that's pretty good. But what lived inside of that at one point when we were quite small? Think back to your fetal circulation. Yeah, I love that. That's going to be the umbilical vein that brings us back into our liver circulation. Now, what kind of blood is carried in the umbilical vein? Is it oxygenated or deoxygenated? Oxygenated, exactly right. So that's going to come back to our heart because mom has to oxygenate our blood before we can do it while we're in utero. Does anybody know the origin of the umbilical arteries? In the fetus, where do they originate from? Why are there two of them? There you go. They originate from the iliac arteries, and that's why there are two of them, one for each thigh. Great job, everybody. I'm going to take things back to our anatomy review, and we're going to hit some GI questions.
Awesome stuff.
Can we go back? Are we back online?
We are back onto the deck.
Fantastic.
Perfect. All right, guys. So we're going to apply a little bit now and dive into this next question. And so again, I like the strategy of starting with the question itself. Which of the following arteries is affected? And so we're dealing with, we need to identify a diagnosis and then what might be driving that diagnosis. So we have a 62-year-old patient with a history of osteoarthritis on naproxen, presents with blood in his stool. 2 weeks earlier, the patient presented to an outpatient provider for several weeks of gnawing epigastric pain that worsens with food intake. So I'm going to pause right here. What do you guys think might be going on based on the data that we have available to us so far? Love it. Perfect. A gastric ulcer. The patient's on an NSAID, which is a risk factor for ulcer disease. And especially when you get that vignette of an ulcer that worsens with food, that's kind of characteristic for it. I think in the real world, it's far more complicated than that. Not quite as straightforward, but that's a very helpful tip-off. On presentation now, the patient also describes lightheadedness and progressive abdominal pain. His vitals are temperature of 37.2. He's tachycardic, a little hypotensive, and he's tender to palpation to epigastrium. They do an endoscopy and shows a bleeding ulcer in the lesser curvature of the stomach. So we already know all of it. Everyone who said gastric ulcer, you're exactly right. And so now comes the anatomy part. So we have an ulcer in the lesser curvature of the stomach that's causing blood in the stool. So what happens oftentimes is you have this vasculature that comes off of the celiac trunk, and it's going to perfuse a lot of these structures in the upper abdomen. What are you going to erode into if you have an ulcer in the lesser curvature of the stomach? Which of the branches off of that celiac trunk is going to get affected? Perfect. Perfect. Everyone's chiming in with E, and you're exactly right. So clicking through to the next will confirm that we're right, and we are indeed, is the left gastric artery. So again, this is kind of a tried and true vignette, one that you're commonly going to see. There's kind of a series of different ones of ulcers in different locations. And I think just having a good idea of what's coming off of that celiac axis and kind of roughly where things are. And the main ones I want to highlight for you, have a general sense of where the splenic artery goes, where the left gastric artery goes, where that common hepatic artery goes and how it branches into that proper hepatic artery and the gastroduodenal artery. These are some of the high-yield ones that commonly come up. But great job, guys, on that question. Keep moving forward. This is a painful, painful thing that there are a lot of questions you're going to come across in question banks and in reviewing things about where are things draining if you have issues in the anal canal and the rectoanal area. And so there's this basically it's a demarcation that we call the dentate line, and that, or the pectinate line is the other term that's used. And it kind of interdigitates in a way that kind of makes sense, kind of like tooth-like almost dentate. But the point is, it is rote memorization to state it like it is, but it's almost like things distal to the dentate line are more like our normal skin. Okay, and everything proximal to the dentate line internally is more like our bowel. It's kind of like bowel meets skin. It's like, where is the end point? And so if you are below the dentate line, you're going to have a squamous epithelial lining, just like our skin. You have that like all of the keratinocytes that array and stratum corneum, stratum granulosum, stratum spinosum. We can go on and on about derm path. And then if you're above the dentate line, you're going to have more of that intestinal type epithelium. So that pseudostratified columnar epithelium with goblet cells and mucin. And similarly, if you're above the dentate line, you're more bowel, so it's going to be more endodermal in origin. If you're below the dentate line, you're more skin, so ectodermal in origin. And then this is where it gets high yield, is knowing the drainage of these things and where they go. So above the dentate line, you're going to the internal iliac lymph nodes, and you're draining into the portal vein via the superior rectal vein. Below the dentate line, it's more of a caval circulation. You're draining via the rectal vein into the IVC, and you're draining to the inguinal lymph nodes. High yield stuff right here, though. They love questions on the dentate line. And happy to field further ones of those if you guys have them going forward. But anyway, so moving on, we'll keep plugging along and move on to some neuroanatomy now.
Sorry. If you'll have me, I can contribute a little bit to the neuroanatomy conversation, just to go over some very, very basic stuff that we all may need to be familiar with. And for the purposes of here, I'm really just going to focus on the brain. Let me try this again. Can we see everything, including my pointer?
Yes, perfect. Everything looks great.
All right, fantastic. So this is an MRI. It's not a CT scan. It's a little bit of a different kind of study that I'm showing you here now. And I'm showing you a few different projections of the brain. My top two images here are going to be sagittal reformats of the brain. My one that I'm scrolling through right here is an axial view of the brain. And this one over here in the bottom right of the screen is going to be my coronal view of the brain. Okay, so we can look at some major brain components here and hopefully give some of you a little bit of your bearings. Okay, so starting at the midline portion of the brain, we can see a lot of pretty ideal anatomy over here. We've got our frontal lobe all the way in the front, aptly named. We've got our parietal lobe just behind it over here, and we've got our occipital lobe further back here. These are all supratentorial structures. This is the tentorium cerebelli. This is the divider between my supratentorial brain, my lobes that I just talked about, and then this sort of foresty or foliage appearing organ here. This is my cerebellum in the back over here and below the tentorium cerebelli. Okay, this midline structure that looks kind of like a big comma is my corpus callosum. Okay, there are four components to the corpus callosum. Okay, this is the genu is going to be up here. The rostrum is kind of the nose. This is the splenium in the back, and this is the body kind of bringing the splenium to the rostrum of the corpus callosum. That might be a little bit out of scope for what you have to know. I don't know if I remember that entirely, but now you know it. This wizard hat, not an adrenal gland, will experience that, but we can trace out kind of this Santa hat or this wizard hat on top of the beginning of the brainstem. The first wizard hat component, if you're looking at it on a sagittal view over here, is going to be our midbrain. The tip or the snowball of the Santa hat, you know, the white puffy ball all the way at the end of it, is correlated with this bumpy structure over here, which correlates to our mammillary bodies. Okay, mammillary bodies come in as a piece of neuroanatomy that is very important in a particular pathologic diagnosis. You can see mammillary body necrosis in what kind of patient presentation? This is a question of the group. What kind of patient would I expect to see who comes into the ED with altered mental status with necrosis of the mammillary bodies on it? Yeah, I'm seeing Korsakoff psychosis, Wernicke encephalopathy in a patient with alcoholism. Let's make this interesting. Let's go into the biochemistry of this. What is the biochemistry that is causing this to happen? What did you do? It's thiamine deficiency. That's absolutely right. So you gave that patient a piece of cake when he probably should not have had a piece of cake to eat because you've given him too much glucose. He cannot process it. His thiamine cannot, it's not available as a cofactor for, I want to say pyruvate dehydrogenase, if I'm thinking about that correctly. Correct me if I'm wrong.
It's used in a lot of the, I think the decarboxylation reactions.
That is very true. But yes, very good, everybody. Korsakoff psychosis, Wernicke encephalopathy, mammillary body necrosis. That's where it's going to be located right there. This big belly in front of the Santa's belly over here, anterior facing, this is our pons. Okay, this is going to be the pons over here. Lots of different neurons passing through there. I won't bore you with all of the various tracks that you'll have to know at this current moment in time. And then sitting just immediately inferior to the pons, we've got our medulla right down here. Okay, this is going to be where our fibers cross as they descend or ascend into the spinal cord. I should say our motor tracks cross, not our sensory tracks. Our sensory tracks cross lower in the spinal cord. Looking at some other brain anatomy that is quite helpful over here, and I'll kind of correlate with my axial T2. So this is a T2 weighted image for those of you who are curious. I know that because my water density here is going to be, or not density, but my water content is going to be quite bright. Okay. And I'm showing you these midline structures over here. These are going to be my lateral ventricles. Okay. These are CSF spaces. This is the first part of the ventricular system in the brain. These squiggly lines over here help to make the CSF, okay? And CSF is going to flow in a stepwise pattern. It's going to go from our lateral ventricles down to this midline structure, which is my third ventricle, okay? And then it's going to go down the cerebral aqueduct, which is right here, anterior to the midbrain, okay? And it's going to descend as it goes posterior right into the fourth ventricle right here. And the downward midline exit of the fourth ventricle, you can see it right over here in my sagittal. Again, this is going to be the foramen of Magendie. And then the lateral exits of the CSF into the area that bathes the spinal cord is going to be the foramen of Luschka. Remember that foramen of Magendie M for midline. So that's going to be your solitary midline. Luschka is going to be your lateral exits of that CSF. So L for L and M for medium or medial. Good job, everybody. That's going to be basically the flow. So again, these are my lateral ventricles kind of extending from the occipital horns anteriorly. My midline structure over here is going to be my third ventricle. Okay, this is going to exit over here down the aqueduct into this triangular on my sagittal view, which is my fourth ventricle down there. Couple of other fun little anatomic ideas over here. We've got two globes. These are our eyes anteriorly here. These big pipes that bring our eyeballs back into the brain are going to be our optic nerves that we can see. This is cranial nerve number 2. Okay. These flow voids, these dark circles here that follow a squiggly course are our internal carotid arteries as they enter the brain. Okay. This dot that sits anterior to the pons on our axial view here is the big artery in the back that rises up along anterior to the brainstem as it goes up. Does anybody know what vessel I am talking about here? The basilar artery, absolutely correct. Infarctions of the basilar artery lead to what neurovascular syndrome that you all need to know for step 1? Locked-in syndrome. Very, very, very good. Fantastic. I'm going to show you the brainstem again on our sagittal view over here. I'm going to bring you down to the level of Mickey Mouse. Okay, if you see Mickey Mouse in the middle of your brain, you are at the midbrain. Okay, Mickey Mouse is the midbrain structure right here. Again, Santa's big belly right here is going to be our pons. The pons has an inferior component as well, which is our cerebellopontine angle you can see on these sides, but this is also where kind of those cerebellopontine fibers will cross. And as we go down, we hit the medulla, which kind of looks like this upside down butterfly, if you can all hallucinate with me. This is how you know you're in medulla. This is how you know you're in the pons. This is how, if you see Mickey Mouse, you're seeing that you're in the midbrain. Mickey Mouse kind of gets a little bit more triangular as we go up here, and there are these areas of dark foci anterior to this. These are going to be where your motor tracts are going to descend. And then there's also two kind of winking Mickey Mouse eyes here, which are basically going to be your red nuclei, if you remember what those are from your neuroanatomy course. The gyri are the squiggles, the sulci are going to be your valleys in between those squiggles. I'm not going to get into too much of the surface anatomy of the brain because I think it's a little bit out of scope. But what I will cover finally, kind of to wrap up, are some of our basal ganglia, which are important anatomic structures to know inside of the brain. This guy over here is our caudate nucleus that sits anterior, adjacent to the anterior horn of the lateral ventricle. Okay, these are our these lateral ones over here. I'm just blanked on the name. I'm having a stroke right now. I'm not actually having a stroke, I promise you. Substantia nigra was going to be anterior in our midbrain over there. These are our CPS stands for caudate. Putamen, thank you. CPS-P is the putamen. Absolutely right. Very good. Thank you so much, Michael. And then our paired kind of bean-shaped structures here as we go a little bit lower are our thalami. These are the thalami on both sides of the aqueduct down there. We've talked a little bit about the cerebellum already. I don't have much to add there. And here's our spinal cord as we descend into it. I think that is all of the major anatomy I wanted to show you on this. I'll throw you one extra bonus question here. We've got a beautiful corpus callosum over here. If we were to see little hyper intense wedges kind of coming out of the corpus callosum up here in a patient who has kind of these new onset neurologic deficiencies, whether they have numbness in their leg or they have an optic neuritis for some reason, it comes and goes, it relapses, it remits. That's a buzzword. We're seeing Dawson fingers of MS would be the things that kind of radiate out of there. That's a common step 1 question. I'm seeing another great question here. Where is the adenohypophysis? That's the anterior pituitary gland. The pituitary gland is going to sit in our midline structure right here, which is the sella turcica. Okay, and it is this bright structure right over here is going to be our pituitary gland that sticks right down into there. That's our cavernous sinus. I wonder if I can get you a better picture of it here. This is the cavernous sinus region over here. This is going to be the sella. This is going to be the pituitary gland sitting right inside of it in the mid portion. Okay, And I can maybe show you the pituitary gland about right here as well on our coronal. Great job, everybody. Thanks for paying attention for all that neuroanatomy. Let's jump into more questions.
Awesome job, guys. All right, so we'll do a couple of questions to apply this. So again, we'll start off with, so this is an example more of a schematic style. And so which of the following nerves may be affected by the process occurring in this patient? So again, multi-step question here. We have to figure out what the process is that's happening and then map that back onto a nerve. So 19-year-old is brought in for evaluation after a skiing accident, which he suffered trauma to the side of the head. He was initially unresponsive, but regained consciousness for a brief period of time and has become progressively more obtunded since then. His vital signs are notable for a heart rate of 48 and a blood pressure of 182/71 with an abnormal respiratory pattern. And then CT of the head demonstrates a left-sided lenticular opacity. So what do you guys think? First, what's going on in this patient? Let's start with the diagnosis. What stands out to you guys as the diagnosis here? Perfect. Great, love it. Awesome. Everyone's chatting, that's perfect. So epidural hematoma is exactly right. There are a couple of clues here. The lenticular opacity, the kind of lucent period, where you initially unresponsive, kind of go back to normal and then become progressively worse is pretty characteristic. Does anyone know the name of these vital sign abnormalities, the bradycardia, the hypertension, and the abnormal, the wide pulse pressure, and then the abnormal respiratory pattern? Does anyone know what that's called? Cushing's triad. Perfect. Exactly right. Cushing's triad. And so what nerve, so this is of course a schematic of the cranial nerves. What cranial nerve is going to be affected in an epidural hematoma? Perfect. Cranial nerve 3. It's exactly right. So this is the kind of blown pupil or dilated pupil that you can see that starts off with the parasympathetic deficits, and then over time you get the motor deficits where it's down and out. Perfect. So what answer choice would that correspond to? Perfect. Everyone, that's exactly right. So A is going to be your oculomotor nerve as it leaves, and it's exactly the nerve that you're going to think about as affected. Great job, guys. Feel free, and again, open invitation as we go. If you guys have questions, chime in at any point. So we'll keep plugging along. We'll apply this to a second question now, maybe a little bit more outside the realm of what we're doing at the radiology, but kind of moving into the spinal cord. We have her presentation may be driven by a disease in which of the following regions? And so we have a 27-year-old woman presents with slurred speech and double vision. Her symptoms developed progressively over several days leading up to presentation. She's otherwise healthy, but reported an episode of blurred vision and ataxia 2 years ago that self-resolved. Her exam is notable for decreased sensation of pinprick on her abdomen left of the umbilicus. Her lumbar puncture is notable for oligoclonal bands. So what do you guys think is going on here? What diagnosis does this make you think of? Perfect, MS. We have the buzzword that you're going to want to look for in a vignette for MS is dissemination in time and space. And so they're going to give you some character, they're going to give you some story that doesn't map onto a singular deficit. There's not a single lesion that could drive everything that we're seeing. So slurred speech, double vision, and then decreased sensation of pinprick on our abdomen left of the umbilicus, that doesn't really fit perfectly with a single point in the brain that I can think of, or in the spinal cord, and it makes you think about dissemination in space. And then she had this episode 2 years ago, a blurred vision and ataxia. So we have dissemination in time too, dissemination in space and time. And then the oligoclonal bands is a little bit of a buzzword. So now what they're asking us is, it's a little bit of a tricky question. What's going to help us get to the answer is her exam, showing decreased sensation of pinprick on her abdomen left of the umbilicus. So what tract is affected here? What tract serves sensation of pinprick? If you're kind of sticking someone with a pin, that would be a little bit painful. Pain and temperature, we're thinking spine with the laminic tract. So awesome job, guys. Spine with the laminic tract. Now, the spine with the laminic tract, does it cross? Where does it cross? At the level of the lesion or above? the level of the lesion. Yes, great. Wow. So I want to give a shout out to Erica. That's exactly right. So there's this tract of Lesueur where you can move up or down 1 to 2 spinal cord levels before you cross. But the point is that generally the spinothalamic tract is going to be crossing at the level of the lesion. The idea is that you have the dorsal root ganglion, which is hanging out right outside of the spinal cord. It sends off one branch of an axon into your big toe or wherever it might be, whatever dermatome that it's serving. Another branch goes in, its synapses in the dorsal horn, that upper gray matter. That then is going to send off an axon that crosses right there at the level in the ventral white commissure and then goes up on the opposite side. Okay, so if someone has decreased sensation of pinprick left of the umbilicus, but we're looking for something, an axon out in the white matter of the spinal cord, what would that map onto? Let's start with which answer choices point out the spinothalamic tract. What answer choices can we narrow this down to on the basis of knowing that it's the spinothalamic? Perfect, E and F. That's exactly right. And so will this be on the right or on the left? So she has decreased sensation of pinprick on the left, and remember, it's going to be on the opposite side because those fibers are on the left, are crossing over and then going up on the right. And so for this reason, then advancing to the next slide, we'll confirm that we're right.
There might be a typo here, and I want to address this just for a moment. Remember that the spinothalamic tract, if we're thinking about pain, temperature, sensation like that, we are also thinking about these pain fibers as part of the anterolateral system. And typically those are going to be more of your anterior tracts. I think when we're thinking about dorsal root ganglion, we were thinking about sensation, that's going to be more of our fine touch, our proprioception, things like that, which have a tendency to rise in our posterior columns, that being more gentle touch kind of sensation. So I think a little bit of a confusing a vignette there because there was a few things going on. We're going to think exam notable for decreased sensation of pinprick on the abdomen, left of the umbilicus, lumbar puncture notable for all of the gluconal bands. If we're having a hard time feeling the pinprick, the pain and sensory fibers there, I'm going to argue that maybe B could be correct here if that's where we're going.
Yeah, I think it is a little tricky. The main thing I would think about for pain and temperature, think about that spinothalamic tract. And I agree with you that it can be a little bit tricky. There's some overlap with the dorsal columns too. I would, for your guys' intents and purposes, I would think of the dorsal columns as more of like your vibration and proprioception. And I'll have to go back when I was making these slides, it might've been a little bit of a typo on my end as well. But I would think about E more than anything in this case for your spinothalamic tract serving that pain and temperature. And so for the reasons that we talked about, again, you're kind of coming in, you're crossing, and you're going up in that spine. So I'll have to go back and correct this. I think that's a mistake on my end when I was creating these slides. That E is the one that we're going for, and that's a typo on our end. Apologies about that.
All right, so E is the correct answer. So great job, everybody, and thanks for clarifying my confusion.
Awesome. All right.
So I don't have any great musculoskeletal correlates to show for the necessary questions that they typically ask for musculoskeletal anatomy. When it comes to kind of asking in this frame of reference here, they're often going to refer to things like dermatomes, like myotomes, understanding how certain things are innervated. And correct me if I'm wrong, Michael, but I think they love asking questions about the brachial plexus and the lumbar plexus when it comes to these kinds of questions.
They do. And again, to the point of what we were talking about before, honing your study and identifying what's important, I try to give a sense when working with students, I try to give a sense of like how important is what we're talking about. I got to say the brachial plexus and especially the ulnar radial and median nerves that come off of it, 8, 9 out of 10 in terms of yield, very, very important. Same thing, the legs may be a little lower yield, but knowing, the peroneal nerve, the tibial nerves, these are super high yield in the leg, and especially, thinking about foot drop and dorsiflexion and plantar flexion, very, very high yield. So let's apply this to some questions. And we'll start off with a little bit of a This is a little bit of a tricky one. I'm just going to tell you guys up front. I think that the first order might be maybe a little bit more straightforward, but also hard. And then the second order is a little bit more of a challenging one. So so in the majority of people, the nerve affected also innervates which of the following muscles. Okay, so we have to figure out what the nerve is, and then we have to know what it innervates. Okay, so if a 68-year-old woman presents with tingling and numbness in the distribution shown in blue. Okay, so and I'll tell you that this is a little bit of an artifact on the exam. They're not going to make you discriminate different colors. It's just working with the confines of the schematics that we have. But blue is the color that we're dealing with here. It's kind of pointing it out. It's the thumb, the first finger, and the second finger and the third finger. So her symptoms have been slowly progressive over several months, but have become more severe. She's employed as an administrator and spends most of her workday typing. So what do you guys think is going on? What do you think is your diagnosis here? Carpal tunnel. That's exactly right. So this is a good vignette for carpal tunnel syndrome. And everyone's already been chiming in. You're thinking about the median nerve. So now the second order of this question is which of these muscles is innervated by the median nerve? And so you guys are so on it. I'm so impressed with you guys. So I really, truly though, like I do a lot of work with students and you guys are on it. So the answer here, the mnemonic that I use, so the answer is opponent's polysis. Is going to be the main one that you're thinking of. C, D, and E. So there's a small minority of patients. Sometimes the opponent's polysis might be innervated by the ulnar nerve, but for the vast majority, over 80%, it's going to be the median nerve. That's the one I want you guys to think about. That's why I couldn't say every patient, but the vast majority of patients, it's going to be the median nerve. C, D, and E are generally going to be your ulnar nerve, and then B is going to be more your radial nerve. And so those are some distractors to kind of lead you away. But again, knowing those three are your big three for the nerves of the hand. But awesome work on that question, guys. And then we'll move on to, this is just a one-off little point, a quick blurb. I always really struggle, and only mostly because I really struggled with anatomically thinking about this and the muscles that relate to it, the Trendelenburg gait. And so what I want you guys to think about with the problem I always ran into is the laterality. I could never remember like which side should lean depending on which foot you're standing on and how that relates to walking. And so the idea is that your gluteus medius and your gluteus minimus kind of level out your pelvis when you're standing on the foot. The foot that you're standing on, you need to pull down so that your pelvis remains upright. You need to pull down on that same side of the foot that you're standing on so that the pelvis actually stays upright. And if that doesn't work, if you're not pulling down, the pelvis is going to sag to the opposite side. And so I think what ultimately made this click for me, I think there were maybe multiple questions that I was getting wrong in the Q bank that I was using. But what ultimately made this stick for me was seeing a picture like this, kind of embedding it in my brain. But when you have atrophy or a nerve injury, then you're going to have the pelvis sagging to the opposite side of where the problem is. So you stand on your right foot. If you have an issue with your right gluteus medius and right gluteus minimus, your pelvis is going to sag down on the left. Okay, and that just, I think having that schematic helps you realize that they're not contracting to lift it back up. And so that kind of helped it click for me. So just some quick key takeaways to wrap up. Again, clinically relevant. If there's one thing you take away from tonight, the content is the content. You can see this in different contexts. But we tried to really drive home things that we think are important. It's not comprehensive. We can't give you all of the anatomy in a webinar like this. And we do our best to kind of give you as much. And honestly, Fred, that was incredible. I can't say it enough that the walkthrough of all of that does give you a great overview of what's important. But at the end of the day, use questions, use textbooks to get an idea of what you need to know. You don't need to be an expert. You don't need to have an idea of like all the way down to the nitty gritty of every single branch off of every iteration of this artery all the way out. It's not going to be super high. What you see again and again in different resources is the most important thing. Make radiology your friend, and so looking at as many images as possible, and spending time, kind of reviewing this. We'll send out the recording if you want to go through Fred's tutorial. Honestly, I'm very inclined to myself, give myself a crash course. We don't do a whole lot of internal medicine. We more look at the outside of stuff in dermatology, but there, there's a lot of overlap in other ways. And then practice is going to make perfect. The more you do this, the more you see the stuff, the better it'll stick. Any other takeaways before we move on to the Q&A, Fred?
No, I think that was all really perfect. We tried to be as high yield as possible here. You guys are going to do a great job. What I'll also say is just remember, if you need our services or help to get through some of the studying or whatever we can offer for you all, just hit us up. Let us know how we can help. We're happy to contribute, whether you need somebody to kind of walk you through the material, whether you need somebody to coach you into studying the right way, to give you strategies to overcome test taking anxiety, or maybe it's just a coach or a mom or dad like figure to kind of yell at you to get your stuff done. But whatever that might be, people like Michael and myself are here to help in any which way that we can. Please stick around for our Q&A, which is happening right now. You can ask us anything you want about anatomy, about test prep, about strategy, about things on your mind, from experienced people who have taken a slew of these exams. We are here for your help. We are your colleagues. So please ask us anything. We will answer as many questions as we possibly can. If they are especially helpful to the group, we will certainly answer them out loud. And if they are a bit more specific and not necessarily as helpful to everybody, we'll do our best to try to answer them for you all in the chat.
It looks like one question that came in a little bit of resources, more UWorld. I guess a question about like the question banks that would be helpful in reviewing anatomy. And so I can kind of dive in that UWorld is a great resource. For even more for step one, and frankly all of the step exams. And again, I think to our points before about identifying a question bank and practice questions that help you get an idea of what's important and what's not, I would say UWorld is a great starting point, and definitely something that I used when I was kind of in your guys' shoes and studying for these tests.
Somebody's asking here a pretty good question about which NBME would you say is a must-do before exams? I don't think that there is any one NBME that is best to do at any one time. I think you should do any one at random. They are all pretty equally balanced. I would not necessarily listen to the rumors that some are harder than others or anything like that. People who tend to do well on these exams have a tendency to score pretty equally among all of them and should expect to see pretty graded improvement as you continue to study for these tests. So please don't get caught up in which one should I do at what time or anything like that. Treat them all equally. They will serve you quite well with all the practice. Someone's mentioning here that a couple of the exams were considered obsolete. Realize also that if you're taking NBMEs for step one, the material that is tested on step one in the highest yield has been taught and known for about 200 years. So I'm not really sure that they would make any components of those exams obsolete. Remember that step one is a science test. It is not a medicine test. So the science they are testing you on is literally centuries old. So don't worry about it. The more questions you can do, the more practice you can get is only going to help you.
This is a good question here. How do we tell if something will be high yielding? And that is an age-old. It's the reality is that this is what makes it so difficult in figuring out how to study is because you need to get a sense of, it's hard to know what's important and what's not. And the truth is, the answer to the follow-up is so the second part of the question is it just by how much the topic shows up in the practice questions? My answer is kind of yes. The more you see it in first aid, the more you see it in your practice questions, the more you see it in other textbooks, That, should be a signal. If you're seeing it across review resources, this is something important. And so that would be my biggest piece of advice is, if you're seeing something and over time, repeated, that is exactly right. Something that I try to commit to memory.
And I'll just piggyback off of that, Michael, because that was a great answer. I think that if you're looking for a list of high yield subjects, look no further than first aid. First aid is everything you need to know, cover to cover, no more, no less. I like here, what do you suggest we focus on for the last 2 weeks before the exam? This is a great question. Really kind of focusing more on the strategy of how to kind of bide your time and think about what to do. In the last 2 weeks, you're probably exhausted. You're probably not willing to read any new information. Committing things to memory has already been done. You're probably at your wit's end. And if you have to sit down at your desk for one more second, you're probably going to pull all your hair out. I don't blame you. I remember being there. I was you. What I will say, though, is that you might be able to pass the time while keeping up your skill by doing and focusing on more practice questions and practice exams. So at this point, 2 weeks into the exam or before the exam, I would focus on doing practice questions and tests, going back through those practice questions and tests and reading up only on the material that you weren't sure about or the ones that you had gotten wrong to correct your ways. The majority of the things, if you're getting them right for the correct reasons, then there's really no need to go back and belabor the point. If you've got things right for the wrong reasons, you definitely want to go back and refresh your memory on those concepts.
There's a question a little further back as you're reviewing, is it worthwhile to cycle review of anatomy systems or focus with one and then move on to the next? So I'm a proponent of, you can go either way, and not just with anatomy, but with all of your preparation. Are you going to go by organ system? Are you going to mix everything together? And I'll tell you that my general rule of thumb, I like to do mixed. I like to keep things kind of all combined. On the exam, you're not going to have the benefit of knowing that you're dealing with a cardiac anatomy question when you move on to the next, when you click next. And I think seeing everything kind of mixed together takes out some of the bias that you might have in approaching a question and makes you take a step back and start from scratch. So generally what I like to do is do everything kind of mixed and all together. If you have a longer study period, you have the ability to make multiple passes, then you can be very thorough and go in a very deliberate kind of today's cardiology. And so I'm going to focus on cardiac anatomy and then cardiac phys and so on. But if you're a little bit more pressed for time, or if you want to keep it as consistent with the test day experience as possible, I would do everything mixed. All right. And then I think that folds to a question that just came in. If you're doing things mixed, then the questions you do should be random and mixed. Maybe we can do one more.
Sure. Let's see. I like this question about kind of test taking strategy during the exam or scheduling your breaks. Kind of the general format of the test, I think, is not a bad idea to review. Step one is a really kind of like a 7-hour commitment, or I should say more like an 8-hour commitment, with 7 blocks and a 45-minute to 1-hour break. You can break up the day really however you want, because that 45 to 1 hour is going to be given to you at your liberty. If you don't do the tutorial in the beginning of the exam, you can have 15 minutes to basically add to your break time and use that for additional snacks or whatever it is that you're going to do. Your time is your time. So one, I would say if you had a pattern of breaks and eating and coffee and whatever that you employ during your study, during your 8 to 10 hour marathon study sessions, then I would try to keep it as consistent as possible if that has worked for you and got your brain into the right mode of thinking. If you're like me, I wanted to be a bit more strategic about my test and breaks, and I knew that I had to force myself to take breaks, because if I didn't, then I would get lazy and make silly mistakes. And for me, I also knew that I was more energetic in the beginning of the exam, because when you sit down to take the test, you are going to have an adrenaline rush. You will be awake, energized, ready to do this. That will gradually fade over the course of the day. So what I did, and this is per my recipe, it doesn't work for everybody, but it can certainly work for all of you, or some of you, or none of you. I would start the exam. I did 2 blocks back to back, and in between block number 1 and block number 2, I just stayed at my seat, stretched out my arms, did like a little bit of just local movement before I was ready in that 30-second gap period, and then started block number 2 right away. After block number 2, I forced myself to stand up and take a 5-minute actual break. I could go get a snack during that time. I could go jog the hallway at that time. I could go outside, get some fresh air. Whatever I had to do, I just had to make sure that it was a limited 5-minute break. At the end of 5 minutes, I came back and I did the exact same thing for blocks 3 and 4. I went block 3, took a very minor in my seat, did not leave the room, upper body stretch break, jumped right into block number 4. At the end of block 4, I was already more than halfway through the test. At that point, I gave myself 20 to 25 minutes for lunch, took my time, walked around, ate a sandwich, did what I had to do to stay energized. And then I went back to take blocks number 5, 6, and 7. And I forced myself, because I was now post sandwich here. So you can imagine what that would do to somebody. I forced myself to take a break after every one of the remaining 3 blocks. Simple 5 minutes, nothing crazy long, just get up, walk around, shake it up, stay energized for that group of maybe 35 to 40 questions that might be waiting for you. And I found that to be quite successful for me. Michael, I don't know if your strategy was similar or different, but would be interesting to hear your thoughts.
Yeah, I agree. I think that there's no right answer here. You can figure out what makes sense for you. But I am a proponent of taking more breaks and giving your brain a little bit of time to rest. My one plug is do the tutorial ahead of time, and then click through it on test day. So you can free up that 15 minutes and have your full 60 minutes of break time on test day. Don't feel like you need to use up any of your break time doing a tutorial that you could have done. It's on the, and to find the tutorial, it's on the USMLE website. I think if you Google search, you'll be able to find it relatively easily. But I would do that ahead of time, and then you'll have the full break time. All right, guys, let's wrap up for tonight. Thanks for bearing with us through the duration of the webinar. We hope this was helpful tonight. It was great to be able to spend the evening with you all. Hopefully, if you weren't a huge fan of anatomy questions before tonight, we hope that we've somewhat, if not completely, changed your mind on that. Just want to put a plug one more time again for the survey, if you've got an opportunity to do that. Very helpful for us. But again, hope you all have a great night, and thanks so much for joining us.